Thank you, Dr. Ahmed Adlan, for the introduction, and thank you, Nujen, for inviting me to speak today. I am delighted to be here, and good morning to all our colleagues joining us this morning from Sudan especially, and obviously from all over the world. I would also like to thank Dr. Abdulazim and Dr. Hind again for giving me the opportunity and inviting me to speak today. Before I start, I just want to just spend a moment of gratitude and remembrance to all our friends and family that we've lost to COVID-19, to all our colleagues that we've lost to COVID-19. And I would just like to say that for all the healthcare professionals and my colleague all over the work, it has been a difficult and a challenging time for all of us, facing the unknown, having to make difficult decisions every day with the lack of evidence. And today I will be talking about coagulopathy and thrombosis, as well as anticoagulation issues in COVID-19 patients. I have no disclosures. So what we will cover today, we will touch on what we know and what we have seen so far. A lot of people have been postulating lots of mechanisms for coagulopathy and pathogenesis for thrombosis in COVID-19 patients, and I will touch on those. D-dimer has been the topic of discussion of many sessions, so we'll touch on that. I'll share some data on the coagulopathy described, and we will go through the management using a case presentation, which will cover the different challenges of thromboprophylaxis and anticoagulation. And lastly, I would like to share our practice, and I hope that we can learn from each other, and then we will end up with some take-home messages. So the novel COVID-19 virus obviously has become a problem. It was first described in Wuhan in December, and the most striking problem is the severe pneumonia and acute respiratory distress syndrome that has been seen. In March, it's been declared as a world pandemic, and the challenging patients that we face are those with severe illness that progress to ARDS, organ failure, and require ventilation. And this is the numbers up to date. I kept on changing it every day because the numbers are changing so quickly. We have 12 million cases. And although the recovered numbers is much higher, but we still have a considerable number of deaths of over 550,000 all over the world. Moving on to coagulopathy and thrombosis, in 50% of patients, both coagulopathy and thrombosis has been described in COVID-19 patients. The other thing that was striking is the massive rise in D-dimer, and that has been described as the most significant change in these patients. And when you look at the other coagulation parameters, you see the rise in D-dimer, but you don't see what you're expected to see with that, which is the low platelets and the low fibrinogen, and that was of interest to a lot of people. Is this a surprise? Not at all, because we know that sepsis, inflammation, and hypoxia, they're always associated with a massive activation of the coagulation cascade. In fact, it's an effector to all of those. And we see 3 of them in a very ill COVID patients. We see profound inflammation, we see profound hypoxia, and it's not a surprise that our coagulation cascade gets activated. If we then try and look specifically at COVID-19 infection, and I would like to point out that this has been described beautifully by Professor Beverly Hunt from Guy's and St. Thomas's, is that when you get infected with COVID-19, the virus binds to your ACE2 receptors, and you find those in your airways, your lower lungs, and the endothelium of your small intestine, the heart, and the adipose tissue. And the part about the adipose tissue is important because there has been a link, obviously, between high BMIs and obesity and severe infection in COVID-19 patients. As we previously said, a lot of these patients recover. However, we get in 5% massive inflammatory response and what we call a cytokine storm. And we see that those patients develop ARDS and require mechanical ventilation. And one of the postulations is that the profound thrombotic state is sort of mediated by some of our prothrombotic cytokines like your interleukin-1 and interleukin-6. And we know that with very high interleukin-6 levels, you see very high fibrinogen levels, and I'll share some data about this later on. Again, is it a surprise that we see coagulopathy and thrombosis? Not at all. If we apply the basic principles of risk factors for thrombosis, an acute illness, those patients are bedridden, whether they are at hospital or at home because of how sick they are, the fevers, the GI symptoms, the organ impairment, and as well as their comorbidities. And then you move on to look at the blood test abnormalities, the raised D-dimers, the injury that happens, the suspicion that they are in DIC. So this is all, again, not a surprise. We see multiple risk factors for thrombosis in these patients, as well as coagulopathy. I would like to introduce you to the idea of thromboinflammation. And this has again been touched upon by some of the prominent coagulation and thrombosis professors around the world. It's the fact that when they did postmortems on COVID-19 patients and looked at their lung tissue, they also, obviously, they found the inflammation, they found the extensive damage, they found lots of fibrin deposition in the extravascular areas, but they found multiple microthrombi. And this is actually one of the major issues in COVID-19 patients. So you don't necessarily, it's not just the gross DVT or the massive PEs, it's actually the microthrombi that you see at the organ level. And this is basically directly related to lung injury. Moving on to D-dimers, if we go back to our basics, a raised D-dimer in inflammatory states in very sick patients is something we already know of, it's not new. And if we go back to why we get D-dimers, our common pathway, which is the fibrinolytic pathway, where you get the plasmin breaking down your fibrin to fibrin degradation products. And basically your D-dimer is a measure of the fibrin degradation products. But actually, it was postulated that there were different reasons why we have a raised D-dimer in COVID-19 patients. I take you to the slide. If you look at the right side, this is actually a postulation of increased D-dimer internally at the level of the lung. And this is because of lung injury. So when the lung tissue get injured, the endothelial cells, they release urokinase, and this is a protective mechanism to promote healing. And through urokinase pathways, they can be breakdown of fibrin and release of fibrin degradation products, and hence a raised D-dimer. And this is one of the theories that this is why your D-dimer is a sort of a prognostic marker or a marker of mortality and severe morbidity in these patients, because the more your lung damage, the higher the D-dimer, and obviously the higher the mortality. The third theory is the macrophages. Obviously, with lots of inflammation going on, then we know again that the macrophages can act on your plasmin, they can break down fibrin, but also there's another pathway where your macrophages can actually again bind to receptors that can break down fibrinogen. And I won't go into the details of the physiology, but this is again another mechanism where macrophages can directly release and produce fibrin degradation products. So those are different theories of why we have raised D-dimers in these patients. Now let's look at some data, and I would like to say and point out that the data that I'm going to share in this presentation, it's all retrospective observational data. You know that we don't have RCTs, it's all retrospective analysis of data and observations that has been shared. And I must say, when it comes to coagulation or thrombosis, we have learned a lot from our Chinese colleagues and our colleagues in Europe, because obviously they've been hit by COVID much earlier than us. So this is a first paper from China, one of the first described, and you can see that they've seen that in all patients, up to 46.4%, they see a raised D-dimer. And actually, if you move down, the percentage increases in those with severe disease. So again, this was the first observation. This is another study which is very interesting. Again, they compared some coagulation parameters in surviving and non-surviving patients. 81% of non-survivors had a raised D-dimer. But that of data is your platelet count. What we're used to is when your D-dimer is very high, you get a drop in your platelet count. But actually, in COVID-19 patients, it's only in 20% of non-survivors you would see a platelet count of less than 100, which is really a surprise. you would have expected much lower platelet count. And again, this is one of the theories that actually we have seen thrombosis more common than bleeding in those patients. Again, the data from China, this also illustrates how in survivors and non-survivors, you get raised D-dimers. And if you notice also, you get a mild prolongation of your PT. And in some labs, you do an INR measurement for PT, and you can really miss this mild prolongation if you do an INR. Again, if you look at the fibrinogen, we are actually getting raised fibrinogen levels rather than the fact with a raised D-dimer, you would expect your fibrinogen to go low if you're actually heading into DIC. So these are all sort of interesting observations. And it led to the question, so if we're getting very high D-dimers and we're not getting low fibrinogen and we're not getting that low platelets, is this really DIC? Can we call it DIC? Is it the DIC that we really see in critically ill patients? Again, as I said, it's not typical because the platelet count is not as low, the fibrinogen is high, and actually the D-dimer levels that we're seeing are sky high. And we have a sort of scoring systems for DIC where you can apply the parameters and see if this patient is actually in DIC. And if you actually use the scoring systems that we have, I would give an example for the ISTH classification, which is the International Society of Thrombosis and Hemostasis. Those patients would not score as DIC. And that's why we are now moving from using the term DIC to COVID-associated coagulopathy for this reason. If you try to go back to basics, you treat the underlying disease if you have this, but actually, obviously, we're faced with a new virus that we don't have much treatment for. So I'm now going to take you through a case, and we will be sort of going through the dilemmas and going through some of the management challenges that we face with COVID-19 patients. So this is a 56-year-old man, and I'm sure we would have seen a similar scenario on our ITUs and wards. So this is a 56-year-old man with high BMI, type 2 diabetes and hypertension. He was admitted with sort of classical symptoms of COVID-19 infection. Those are his parameters, his febrile, his mildly hypoxic, and his hypoxia corrects with a little bit of oxygen. He's lymphopenic on his blood count. He has a mildly prolonged PT, and normal APTT, D-dimer of 5,000, that is raised. We use gram per liter in our hospital. Obviously, you might have different units, and a raised fibrinogen of 6. So I would like to invite the audience to vote. What dose of anticoagulation should this patient receive?
Okay, so the polling will be live for 1 minute. So far, we got 13 out of 37 respond. So I'm encouraging, can I ask everyone, please kindly put your thought and select one of the options.
There's no right or wrong answer. This is just to get some discussion going.
Okay, so 50% they vote now. Okay, so we got 10 seconds to end the vote. Okay, so we got nearly about 65% out of 37 participants, and we got the result here.
Okay, so sharing the results, 36% of you said they'll give standard dose thromboprophylaxis. 40% actually said they'll give intermediate dose or double dose low molecular weight heparin, and 24% would give full anticoagulation. And this is interesting. So there's a clear split here. There's a clear split between the audience, and this is where we are, and this is what we face every day. Let's move along, and as we go along, we will share what we will do. So I will tell you what happened to this patient. So this patient was having standard dose thromboprophylaxis at the time, given that he was a medical patient admitted to the ward. He didn't sort of flag as someone with severe disease. We go into classification of COVID infections. He didn't sort of flag as someone with severe disease. So this patient received standard dose thromboprophylaxis. So continuing, this patient deteriorated a lot 24 hours later from a respiratory point of view, requiring 15 liters of oxygen, became hypertensive and got transferred to the intensive care unit. Very lucky he got a bed. And he got started on non-invasive ventilation and blood pressure support. On repeat of his blood parameters, his D-dimer shot up to 20,000. Again, he still had a mildly prolonged PT and APTT. So this is, again, very surprising. You would have expected with that rise in D-dimer in your classical DIC to see that the APTT takes off, the PT takes off, and the fibrinogen starts dropping. But actually, this patient had a high, an exceedingly high fibrinogen of 10. So again, let's go into a poll. You might choose to continue on the same approach that you were using, but what dose of anticoagulation should this patient receive at this stage? And I'm just sharing his chest X-ray with you as well.
Okay, I guess you got 10 seconds to go, and then we will get the result of the vote. So far we got 70% voting, and we got also vote from Facebook, people voting on option number 3.
Yes, so again, interesting, we've got a split, and now the split is actually, so we've got 19% still wanting to continue or choosing to give thromboprophylaxis. We've got a 42% of intermediate dose or double dose, low molecular weight heparin. And actually now we've got a rise. So actually 38% want to fully anticoagulate this gentleman. Again, really interesting, and we'll touch on this. Moving on, so 4 days later, again, massive deterioration, and now the oxygenation is becoming even more challenging. So this patient moved on to become intubated and ventilated. He started developing organ failure. He's requiring filtering now on intensive care. LFTs were stable other than a mildly raised bilirubin. D-dimer repeated 35,000, not bleeding, and platelet count is 105. Now, because of the rapid deterioration in oxygen requirements, the intensive care team were suspecting a PE contributing to this sort of oxygen requirement and respiratory failure. The patient was too unstable for a CTPA. However, he had a swollen left leg, and the Doppler did confirm a DVT. What dose of anticoagulation should this patient receive?
Okay, so we got 10 seconds left. And so far, we got nearly 70% respond.
Great.
Okay, and now I'm going to share the result with you.
So this one, 79% of viewers today will choose to fully anticoagulate this gentleman. We still have 18% who would treat him with intermediate dose, low molecular weight heparin or doubling dose, and only 4% that would give this gentleman just standard thromboprophylaxis. Now, I want to touch on this case before moving on to data and sharing management experience. We have this is just one patient who's gone through the classical deterioration that we see in a COVID patient. And we've seen 3 different stages where actually we've seen a split, especially in the very first 2 polls, where when the patient very first presented, we are used to giving standard thromboprophylaxis to patients, aren't we? Actually, you will find that this is not a common practice all over the world, but here in the UK, in someone who's ill, they come into hospital, they get risk assessed, and they get thromboprophylaxis with low molecular weight heparin. But actually, if this was another patient, non-COVID patient, they would have had standard dose thromboprophylaxis. But we've seen very clearly from the poll that there was a split. Nearly half would actually give this man double dose thromboprophylaxis. Moving on to the second stage, when this man deteriorated, we had people who still wanted to continue giving normal thromboprophylaxis. We actually had a similar split who wanted to double the dose of thromboprophylaxis, and we even had a percentage that wanted to give full anticoagulation. And this just illustrates the difficulty that we're facing with COVID patients and the split in opinion and the need to actually answer some questions. You could have argued that when he deteriorated to ITU, maybe the deterioration wasn't just COVID. Maybe he had an underlying pulmonary embolism at the time, and that's why you wanted to give him full anticoagulation. You might, on the other hand, say, well, why would I expose this man to full anticoagulation and expose him to a high bleeding risk when I don't have solid evidence that he's got a clot? Maybe I'll just increase him to a double dose rather than give him full dose. I'm sure this is sort of the thought process that goes through people's mind when we face these patients. And going into the literature, I'll share some data with you, but again, we had lots of publications from Chinese colleagues, Italian colleagues, of colleagues in Europe. But again, bear in mind, this is all retrospective observational data. They're not randomized trials. And also, this actually brought to and shed to light that, as I said, not in all parts of the world that thromboembolism risk assessment is made routinely when patients get admitted to hospital. It is not routine practice that people get prophylactic low molecular weight heparin, especially in China. And I know in Sudan that actually there has been a good move sort of on observation over the last couple of years that clexane has been given to surgical patients and some medical patients. So sharing sort of some data with you, let's go back to the history of where risk assessment for thromboembolism stemmed from. These are sort of leading trials in the 1980s, which illustrated that we do get thrombosis in critically ill patients, and also illustrated beautifully by randomization that we do reduce this risk by giving people heparin. And this is where all the basis of thromboembolism in ill patients and in hospital patients and even post-discharge came from, and the basis of the risk assessment that we now see in hospitals. Now I'm going to share with you the thrombosis data for COVID-19 patients. I would really recommend this article, which is written by my boss, Professor Mike Macris. Now, this is a great summary of 5 Chinese publications describing thrombosis in COVID patients. And it's a mixture of patients who have received low molecular weight heparin and patients who haven't. What you see is that no doubt there is a considerable risk of thrombosis in all groups. But also you can see that even in the groups where low molecular weight heparin has been used, you are still seeing sort of a considerable percentage of thrombosis. You can also see that there has been arterial thrombosis described. So it's not just venous thrombosis. Again, this is another paper from China. Now, again, retrospective and observational. They have compared mortality in patients where they've used heparin and they've not used heparin. And clearly you can see that the mortality is higher in the groups where heparin wasn't used. Now, in this paper, we don't know what was the type of patients. Is it patients who were just very ill? Is it patients who just had thrombosis? We don't know what type of heparin was used, and we don't know the doses. So bear in mind all of those sort of factors. But hence, we're just sharing the observations of what was seen in their patients. Moving on, this is a paper from the Netherlands. They have basically, they use a symptomatic approach where they only report sort of investigated patients who they thought might have symptoms of thrombosis. They had an incidence of 31%, much higher incidence obviously for venous thrombosis, and about 3 cases only of arterial thrombosis. Another paper from the Netherlands, again, no doubt, and this is a screening approach, not a symptomatic approach. They have sort of picked up a considerable amount of thrombosis, and you can see a very clear comparison between your ward patients and your ICU patients. So venous thromboembolism are in about 4% in your ward patients, but actually a considerable rise in your ICU or critically ill patients. And the same paper actually described the cumulative increase in thrombosis with time, because we know that these patients actually spend a lot of time in intensive care. And you can see sort of a plateau on your ward patients, but this is sort of rising rapidly in your ITU patients, and obviously progressively increases with time, which is, again, you would expect that kind of pattern. And lastly, this is a paper from France. They looked at retrospective analysis and reported a cumulative incidence of pulmonary embolism, comparing COVID admissions to non-COVID admissions. And it was 20.6% in COVID patients critically ill and 6.1% in non-COVID admissions. Let's go back to our dilemmas. So this data, no doubt, tells us that thrombosis is a major problem in COVID patients, but it raises a lot of questions. Is a prophylactic dose enough? So just giving your standard prophylactic low molecular weight heparin, is that enough? We have been faced by colleagues who have been very stressed, very emotional, because they are giving their standard thromboprophylaxis, but they're getting thrombosis in lines in ITU, thrombosis of filters, symptoms and signs of thrombosis, and they can't image the patients. And then moved on. Shall we double the dose then, if this is what we're seeing? Shall we give them a higher dose? Shall we fully anticoagulate them, actually? Because actually the thrombosis risk is very considerable, sharing the data. Shall we do this to all patients? Or actually, shall we risk stratify the patients and select only some patients that we would do this on? If we're not going to do it in all patients, which patients shall we choose? What about the risk of bleeding? Because these are critically ill patients who are sort of exposed to lines and different procedures on intensive care, so we can't really ignore the bleeding risk. And the challenge of renal failure and anticoagulation obviously is challenging when you have renal impairments, because a lot of our anticoagulants are cleared using the kidneys. It's only sort of, you're limited with unfractionated heparin really, if you want to anticoagulate these patients. So to answer some of these questions, I'm going to share the practice locally in Sheffield. And this has obviously been more of a national move that has happened in a lot of the centres when they actually looked at the data that I've just shared with you regarding D-dimers and regarding thrombosis. And I'm sure a lot of the centres developed local protocols to help the healthcare professionals in intensive care units and on wards manage prophylaxis anticoagulation issues, obviously with support. So the first thing that came into mind is the data that I shared with you earlier about high D-dimers, and obviously the thrombosis data. And our protocol stressed on thromboprophylaxis. This was the starting point. Everyone should receive thromboprophylaxis. Everyone everyone, unless there is a very strong indication for them not to use thromboprophylaxis. And even patients who had minor bleeding for one reason or the other, they were discussed with the hematologist to try and weigh things. Even the simple thromboprophylaxis, there were lots of discussions about, omitting it. You don't just omit, you think about it a lot. The other thing that we've done is normally you have a cutoff of platelet count of 50 locally to give thromboprophylaxis, and we've relaxed that to 30 to enable a lot of patients to be receiving thromboprophylaxis. That's the first step. Obviously, you use low molecular weight heparin adjusted to weight, so your overweight patients get a higher dose of prophylaxis, and similarly, you reduce it to your underweight patients. And you do your dose adjustments depending on renal impairment as well. Moving on, ICU patients. So this was a very challenging group, the very critically ill, the deteriorating patients. The questions propped up about thromboprophylaxis, is this enough? We don't want these patients to receive thrombosis and complicate things. And actually, looking at data, we developed sort of a local exclusion or selection criteria for patients to get double dose prophylaxis. And those were deteriorating COVID patients. And deteriorating and unstable is very important and very relevant to us, like areas in Sudan, because sometimes you will be working in areas where you can't do a D-dimer test. You can't actually look at what a D-dimer is. And we would encourage using your clinical judgment and your clinical sense. If you're worried about this patient, if they're clearly deteriorating, clearly heading into intensive care, then consider increasing or doubling their prophylactic dose. We used a figure, and again, it was very difficult to quantify in terms of D-dimer, but we used a D-dimer of 10,000 or more, that you would double the dose of their thromboprophylaxis. For patients with renal impairment, we measured their anti-10A level, and again, obviously in Sudan, that might not be relevant, but you want to make sure that you're not accumulating low molecular weight heparin in patients with renal impairment. And the thing to remember in these patients is that you're not aiming to fully anticoagulate them. You just want to provide them with a higher dose of thromboprophylaxis than normal. So when we come to anti-10A monitoring, we only aim for a sort of a peak of about 0.5. You would aim for higher if you're anticoagulating them. Now, the coagulopathy, we got lots of calls about it, or when patients started dropping their fibrinogen, when they become unwell, we got calls about prolongation of the PT, but the routine practice, going back to basics, is that you don't correct coagulopathy with blood products unless you have major concerns about bleeding. This is sort of in all guidelines. The other thing to remember is that in DIC, although obviously we have a question about DIC, but these are patients with very high D-dimer. If you give a drug like tranexamic acid, if you're concerned about bleeding, you inhibit fibrinolysis. And we want the microthrombi, we want fibrinolysis, we want all the microthrombi to be removed from the circulation. So we avoided giving tranexamic acid in these patients. If there was a confirmed clot, we treated them with full anticoagulation, and we used either low molecular weight heparin or unfractionated heparin. And unfractionated heparin was used in people who had renal impairment, a creatinine clearance mostly of less than 20. Once they were stable, discharged to the ward, they were eating and drinking, they were being discharged home, we switched them to oral anticoagulation. The practice here in the UK is that you give DOACs, but obviously if you don't have availability of DOACs and you can do warfarin, then that is very reasonable. Or you can continue giving them low molecular weight heparin for 3 months if they are tolerating injections okay. But the principle is they had a provoked clot. This is a clot provoked by severe COVID infection. They get treated for 3 months. And lastly, I would like to summarize by some take-home messages. No doubt thrombosis is a major problem and very common in ill COVID-19 patients. We didn't see them bleeding actually, despite how sick they were. D-dimers seem to be related to morbidity and mortality, And we think one of the postulations is that it is directly produced by the lung injury. Give thromboprophylaxis to all patients. This is the message. Think about thromboprophylaxis in your COVID patients straight away. And if you decided not to give it, there must be a very, very strong reason for it. Consider, and consider is put in capital letters, because higher dose thromboprophylaxis and the practice that we're currently doing is actually not based on evidence. We do not know if what we're doing is the right thing. And we will yet to know once we get randomized trials that give us some data to tell us that actually we did the right thing. So consider it in your critically ill patients, in your deteriorating patients. And if you have D-dimer measurement, maybe an arbitrary number of 10,000. Again, I don't know if this is the right cutoff. If you have thrombosis, fully anticoagulate your patients. This is the principle that's used in all thrombosis, and treat it as a provoked clot for 3 months with whatever anticoagulant you have available and is suitable. Always remember, just for all thrombosis and anticoagulation decisions, always individualize it to patients, because patients are very different. The bleeding risk is different from one patient to the other. The organ damage is different from one patient to the other. So always personalize your decisions. And if you work in a center where you can enroll patients to randomized controlled trials, I encourage you to do so, because this is how we're going to find out what we're doing is right or wrong. And this is how we're going to know what is the optimal management for these patients. So we don't know what the right dose of anticoagulation is or thromboprophylaxis. And if you look at societies, so American Society of Hematology, the ISTH, so the International Society of Thrombosis and Hemostasis, this is just considerations. This is not based on solid evidence. So we're just sharing practice. And I leave you with some questions, some interesting questions that I have in my head about what is the correct doses of anticoagulation. We've recently found out that drugs like dexamethasone improve outcomes in COVID patients, and we know steroids reduce inflammation. Does this mean they will reduce microthrombi? They will reduce thrombosis as well? Again, very interesting. We've never really touched on platelets, and we know that platelets play a major role in thrombosis. So is there a role for antiplatelet drugs? Again, this is an interesting area. And what about patients when they leave hospital? Is the risk of thrombosis following them when they leave hospital? Do we need to think about extending the prophylaxis for patients when they leave hospital? This is another interesting area. And with this, I would like to share some very useful resources and references, very good webinars on this topic. And if you're a fan of Twitter, follow Professor Macris and Beverly Hunt. They tweet about this a lot. They share really interesting papers. So this is for further reading. And I would like to thank you for listening.
Thank you very much, Dr. Khalifa. That was really a fantastic talk and really comprehensive. And thank you also for introducing the polls. That was really, really nice to see that. There's so many, important learning points from this topic. And I think one of the take-home messages that I've got from your talk is you have to consider thromboprophylaxis in every patient with COVID. It's really, really important. So I think at this stage, I'd like to invite the panel members, Dr. Fatma and Amin, if anyone has any comments or any questions that they'd like to ask.
Thank you very much. Thank you very much, Ahmed. First thing, I would like to thank Mai. MashaAllah, that was such a fantastic and excellent presentation, which I enjoyed thoroughly. So thank you very much. I'm sure all the attendees here find it very useful. I have one comment and actually just 2 questions to ask Mai. My comment is actually, as you commented, Mai, most of these data are coming from observational studies. So we have to be quite cautious when we are applying them. It is very interesting actually to know, when I was going through ISTH presentations, that there is actually a trial now, randomized control trial, which is being done in USA and Canada. And it is called RABBIT trial, which is looking at COVID patients during their first 3 days of admission to the hospital. and trying to compare using a standard dose low molecular weight heparin or unfractionated heparin versus double dose or intermediate dose. So I think the result of that trial will be very interesting, and it will be very helpful for people. And it is actually good to know that they are trying to incorporate people of minor ethnicities, so Black people and other people of ethnicity, because we know that from observations that those people have got higher mortality, high risk of thrombosis, and they usually have higher D diameters. So it is very good to see the result of that trial. I think they are trying to get the result of that as quickly as possible to us. So I think that would be very useful. One question that I have got for you is actually, you already touched on it in your presentation. It does seem that like diagnosing venous thromboembolism in those patients, COVID patients, is really challenging. Can you just touch on that? What did you see in your practice, like during this COVID period? Like how do you diagnose those patients usually?
That's a really good question, Fatma, actually, and we've touched upon this on the case that I've shared. So if you notice, the suspicion actually was this patient had a pulmonary embolism, but it's not uncommon that in critically ill patients, having imaging when the patient is unstable is not feasible all the time, and it's sometimes postponed until the patient is more stable, and you have to take clinical decisions. Luckily for this patient, they did a Doppler, which is obviously much easier, can be done at the bedside, and they confirmed the DVT, and hence they found the clot and they anticoagulated the patient. But actually, sometimes you don't find a DVT. You can't do a Doppler. You don't have those facilities available, and this is where clinical judgment comes in. And if you have a strong clinical suspicion that actually, I think this patient might have a PE on top of, the ARDS or the pneumonia, then you would be leaning towards increasing their anticoagulation, and that would be a sensible clinical thing to do, provided that there's no bleeding risk. And these challenges have been faced even in bigger centers, as I said, where imaging modalities are available because of how unstable and sick those patients are. And similarly, if we look at Sudan, we don't have the availability of imaging and the luxury of imaging, and this is where clinical judgment, overrules, and using your clinical judgment and suspicion to increase anticoagulation if you feel it is safe to do so.
I agree with you, Mai. That is really good point. So things like rapid respiratory deterioration, I guess, sudden rise in D diameters could be considered as a could raise clinical suspicion that this patient has got a thrombotic event, isn't it? Just well second question.
I would say hemodynamic. If they have any hemodynamic instability as well, that can sometimes be a sign of a major, massive PE.
Yeah. Thank you very much. My last question, is just, you touched on, or actually you commented on the practice locally in Sheffield, and this is, I guess, the practice in most of UK. What about the other international organizations? So things like International Society of Thrombosis or WHO or American Society of Hematology. Generally, what is the practice worldwide still in terms of prophylaxis in those patients? Has those organization tended to double the dose or keep the dose at prophylactic level?
So again, a very good question, Fatma. If you go to the American Society of Hematology, the International Society of Thrombosis and Hemostasis, you will find that there is no agreement on this. So there is a split. But again, if you go and look at their recommendations, it's just recommendations. It's not sort of based on solid evidence that they would say consider increasing the dose. And this is where the principle of trying to consider increasing the dose and not doing it as a blanket to everyone, but choosing the patients that you would want to do this on. But if you look at those bigger organizations, there is still a split. And this was actually illustrated beautifully with the poll, that actually even here, we as clinicians managing those patients, we can't agree. We can't actually agree on what the right answer is. And similarly, this is very similar to all the bigger organizations. So if you look at guidance so far, it's local practice, it's considerations of increasing doses of thromboprophylaxis rather than do it. And it's do it in selected patients and selected cases.
Yeah, thank you very much, Mai. That was such a fantastic presentation. Thank you.
You're
We
welcome.
just pass it to the rest of the panel and the audience. Yeah.
Thank you, Dr. Fatima. So there was one question from the audience, and they want to know what happened to your patient in your case.
He did not make it.
Okay.
He passed away.
Okay, that's very unfortunate. I had another question, actually. I had Dr. Hind, did you want to?
No, it's fine. Yeah, after you.
Okay. So there were two points I wanted to, or questions I wanted to raise. Firstly, you mentioned about the D-dimer and the fibrinogen, and how we're seeing in COVID this atypical sort of picture. Do you think that therefore that the D-dimer may not just be a marker of thrombosis, but maybe a marker of lung cell injury? Is that something that you've seen in your?
This is absolutely. So if we go back to one of the slides in terms of looking through the mechanisms where you have a D-dimer increase, so we've touched on that, is that actually in the lung tissue, when you get lung injury, there is production of urokinase, and urokinase is very linked to sort of plasmin activation and breaking down of fibrin into fibrin degradation products. And hence, this intrinsic mechanism of producing of a rise in D-dimer is related to lung injury. You also have the macrophages at the tissue level, and the macrophages again bind to receptors in fibrin and break it down. And this is actually why people think that D-dimers are directly related to lung injury, and this is why there's a direct link between morbidity and mortality, rather than the normal pathway that we know of in critically ill patients. So definitely there is strong suspicion about intrinsic D-dimer production at the lung level.
Great, thank you. And the other question I had was regarding the timing of thromboprophylaxis, because you have a patient comes in acutely, you suspect they've got COVID, you know, the patient is clocked in and they've had the blood sent off. It appears to me that it's important to wait for the results of the blood tests and then immediately give the thromboprophylaxis rather than just prescribing it for 6 p.m. and they may receive it the following day. What's your sort of take on that aspect?
So the most important thing is actually how you clinically assess this patient at the point of admission to hospital. I think this is the key point, because you have lots of variation in your admissions. You can get a patient who's actually very stable, not hypoxic, but actually, you know, has starting with a pneumonia. You give the thromboprophylaxis. In terms of waiting for blood tests, obviously the things that you would wait for is to make sure that you're giving the correct dose based on your renal function. You don't want to give them a higher dose. And you want to make sure that they're not massively thrombocytopenic. But even with the platelets, we've relaxed that to 30. But I think the key really is, how ill is your patient? If it's a very critically ill patient, it's about what dose you are going to actually give them. But in terms of blood tests, you can get that straight away. The routine practice is that actually those patients on the ward do get their thromboprophylaxis at 6 o'clock in the evening. But let's say the patient gets admitted maybe 7 in the evening, gets clocked, have their blood tests. Some patients were receiving thromboprophylaxis later. There hasn't been sort of a standard practice or a prompt to that, if you like, locally in our practice.
I guess the challenge would be if they were admitted 1 o'clock in the morning or something like that. I think this is what I'm hinting to, and then they get up having it 6 p.m. the next day. I totally can see that happening in the ward. So
absolutely, and this is what's been happening. And we haven't been prompting that. Make sure you chase the bloods and the first thing you prescribe is thromboprophylaxis. I must admit that is not the case. Obviously, in an intensive care setting, it's very different because the turnaround of bloods is quick, and you know, medications are just given there and then. That's very different. So for the ward patients, it's different.
Great. And one last question from the audience. So what is your trust practice for VT thromboprophylaxis post-discharge in patients with COVID who have a high D-dimer, and for how long? Is that something?
No, so a very interesting question. And this is an area where there is absolutely no data. So we don't have a guideline for that. And we don't have sort of a common practice that we follow. We don't even have any risk stratification. So it's individualized. I've not been directly involved with patients who were discharged on thromboprophylaxis. But I would think if we apply the principles of what we know about extended thromboprophylaxis, this is a common thing in cancer patients, where you would think about extended prophylaxis when they leave hospital. And no doubt in COVID patients, the state of inflammation on thrombosis, I don't think is lesser than that. So this is an area that still needs data, but I must admit we don't have any local guidance on that. It would be individualized if felt necessary by a clinician.
I have a question, May.
Yes.
Thank you for your nice talk. It's regarding patients who are already on a DOAC, for example, for AF or for anything. So they're already anticoagulated, and then they come in, sudden onset breathlessness, you're suspecting COVID, or it could be another kind of event. What sort of, is D-dimer, for example, helpful? Did you expect it to be suppressed, or should we actually be still investigating a PE, or can we just kind of rely that even though they have COVID, anticoagulation with a DOAC, for example, is kind of protective? What's your practice on that?
Just the line was breaking, Ahmed. Is it correct that your question is in someone who's already anticoagulated, if you're suspecting thrombosis, what to do?
Yes.
Yeah. Yeah, great. That's again a very good question, and we actually get this question even in non-COVID setting. It's not uncommon that you get a patient coming to A&E who's already anticoagulated, but you still get a suspicion that they have a PE. I would push for investigation, because failure of anticoagulation on DOACs is not unheard of. So we have seen people who have developed new clots and extended their original clots on DOACs. So this is in general. So I would imaging would change your management, because you would actually consider an alternative anticoagulant. And just on top of that, the COVID patients we are dealing with.
Yeah, no, go on, May. I just wanted to add one point, but I will wait for you to finish. Sorry.
So adding on top of that, your COVID patients, they are a special group of patients which are very prothrombotic. Again, another reason that you would investigate them for new clots. And also, given how sick they are, the common practice has been that you actually, in the acute phase, you anticoagulate them with heparin. We have a lot of experience with heparin. It's an anticoagulant that we've been using for a very, very long time. And switching them to heparin in the acute phase has been a common practice that we have done locally. Even if not a new clot is suspected, just in that very rough acute phase. And the other thing about heparin, whether it's low molecular weight or unfractionated, is you have the beauty of being able to monitor it. You can make sure that you're effectively anticoagulating the patient, unlike the DOACs, where we can measure levels, but we don't have enough data about their levels. I will pass on to Fatima as well if she has anything to add.
Yeah, thank you very much, May. Just one point to add to what you were already saying about heparin. Actually, it is very interesting that the expert in field of thrombosis and hemostasis, from the observation in the COVID period, they think that heparin has got an anti-inflammatory effect, and it is anti-tropic. So they think that it actually affects the binding of the virus to the endothelial surfaces. So they are actually encouraging the use of heparin. I don't think that we have the same evidence for DOACs at all at the moment. So for all the reasons that May already mentioned, and on the top of that, it will be a very good practice. Patients who are coming on DOAC while they are acutely unwell with COVID is actually low molecular weight heparin. And as May, I totally agree with May with what she said in terms of the fact that they are very high thrombotic group. Developing another PE, even if you are anticoagulated with DOAC, is something that can happen. So I agree, if there is suspicion, you need either to investigate them, or even if you are not able to investigate them, is to consider escalating their anticoagulation. So if they are on DWAG, to change them to a treatment dose low molecular weight heparin would be a good practice, I think.
And is the D-dimer at all different in terms of interpretation on a DOAC or not?
It is very good questions. I would say that what we know is that DWACs affect the D-dimers, so D-dimers results are not reliable. I have to say, I haven't been asked this question. I don't have enough information to say how the expert has been dealing with interpreting high D-dimers in patients with DWAC. I don't know whether may have got any experience with that. But
no, again, because D-dimer is not something that's routinely measured anyway in DOAC patients. And also, if you get a DOAC patient where you're suspecting a clot in, you wouldn't do a D-dimer. You wouldn't follow your Wells score, and you would just image them. So that's why this is not something that you'd routinely do on a DOAC patient to get some evidence about how the D-dimer affects it. But one thing that we can say that in COVID patients, the rise in D-dimers, because of the different mechanisms that we've discussed, is invariably affected by anything, because even irregardless of what you're on, medications, etc., the rises in D-dimers that we've seen, we've not seen them before. So I would say probably you would still get sort of really high D-dimer levels, but it's not routine practice. That's why I don't think we'll be able to answer this question.
And I guess the most important part is the clinical suspicions. Like if you think that this patient has got respiratory deterioration, or they have got a swollen leg, or they are clotting their filter, or they are clotting their, circuit, in ITUs, then you have to suspect that they had a thrombotic event regardless of their D-dimers. So clinical suspicion is also a very important point there. Yeah.
Thank you.
Thank you very much, and we've worked you very hard today, May. We've got one last question, and we'll close the session, okay? And then you can have a rest and have a cup of tea. So the question is regarding thrombolysis. Now, is this something that you've had experience with in patients with COVID? And traditionally speaking, we were taught, we're taught that the D-dimer level shouldn't dictate whether you should thrombolyze patients. It's more about hemodynamics. Is that different in the COVID patients?
Not known. Again, this is an area where not known. Whatever we're doing now is just trial basically. So not known. But I mean, if you want to apply the principles of thrombolysis, if you have a very sick patient, irregardless to whether they have COVID or not, then if they fulfill the thrombolysis criteria and they need thrombolizing, you will give them unfractionated heparin after that. So I think you would apply the same principle, but I don't have cases or experience to share with regards to that specifically.
Okay, thank you, Ahmed. If you don't mind, many thanks, May, for this fantastic presentation. And indeed, we learned a lot from your talk. And just before I give you the question, I would like to extend the welcome to our senior consultant, Dr. Mai Khalifa, who joined us this morning. So the comment on the Facebook from one of the respiratory trainee, I believe, she said that in her trust, they used to give like any patient with COVID post-discharge 2 weeks prophylaxis, Plexane, or 2 weeks NOAC. What's your comment on that?
Again, it sounds not an unreasonable thing to do. From patients, and we did have individualized extended prophylaxis in some of our patients, but it's not standard or routine practice, again because it's an evidence-free area. But as I said, if you apply the same principle to your, let's say, malignancy patients or patients with stasis that you would discharge from hospital with extended prophylaxis, if you have concerns that someone is prothrombotic, or let's say their mobility is not great, they have other risk factors for thrombosis, they're elderly, and you feel that actually they have other risk factors for thrombosis, adding to COVID infection, it is not unreasonable at all to give extended prophylaxis. but this is not, again, this would be a very interesting area for trials to see if there's a difference in readmission with thrombosis and things like that. Can I just extend my welcome and regards to Dr. Mahir Hamid as well? I have noticed that he's joined. It's a great pleasure, and it's great to see you here today. And I would love to hear your thoughts about, again, your experience about thrombosis and anticoagulation in COVID patients.
First of all, yes, I'm really happy to see you again, Mai. I've seen you, the last time I've seen you about 5 or 6 years ago. I can't remember when. And
Longer than that.
Longer than that, yeah. And I'm really happy to see you have progressed, and really, although I missed most of the talk, but I think I joined at the end of the talk, and I think it was very impressive. Your answer to the question, I think you answered all the questions. The only thing I want to add here, also I need, sorry, before I go in, also Fatma as well. She's also, I've seen her, also one of my little girls as well. She's fine now. She's a...
Certainly, Dr. Mahir.
Yeah. Right, okay. The important thing here, the only thing I need to comment on, I think everything was, you answered everything, I think, most probably, and I learned from that a lot, really. The only thing is thrombolysis, which I think DDIM have no, there's no correlation between DDIM and the indication of thrombolysis. Thrombolysis is a clinical decision. It depends on the patient, and there are certain parameters like hypotension, hypoxia. If the patient hemodynamically unstable, had a bigger PE or something, you go on and thrombolyze. You don't wait for D-dimer and things like that. So this is the only thing I could say. I think thrombolysis is mainly a clinical decision. It had nothing. D-dimer, I don't think, had any role in that.